I now run part of a group of 5 doctors and a midwife out in Northern Virginia. I think some of you may know about it. It's called the Tepeyac Family Center. And we are a nonprofit OBGYN practice. Anybody who wants to talk to us about it, Cheney Mullins, right here, would love to talk to you about it. We do see externs in our office. If you're going through an OBGYN clerkship and you want to come and see medicine practiced from this perspective. We did it. We put Tepeyac in the name to constantly remind myself. And by the way, this is a medical school, and I'm totally with you. And if you guys need to get up and leave for classes, hopefully this is going to go till maybe 10 till 1 so you guys can get wherever you need to be. Hopefully there's going to be a good amount of question and answers. I really mean it. So we put Tepeyac in the name because we want to see the underserved. We want to see all people. Because when I had my change of heart, it was practice excellent medicine, figure out how to see women who have insurance and who don't have insurance on a daily basis. Don't do it like as a week sabbatical every year or a pilgrimage or whatever you want to call it. Try to do it every day. Because even in the most wealthy districts and counties in the world, Fairfax, Loudoun, on the other side of the river, there's people who still need health care. And to do it in a way that's consistent with the dignity of the human person. That's how it was. That was part of my conversion. And so I went into medicine because I wanted to be the best gynecologist I could be. Now, I'm going to sweat today. It's not PMS. It's not menopause. It's not... I just sweat on hot days like this in here. So the question that my parents kept asking me is, if you do something, do it well. And somewhere in my college years, I became politically pro-choice, pro-abortion. And so here I was in my residency. I had a knack for listening, PMS, hormones. I was pretty good with my hands surgically. The question becomes, how far do you go? Now, I know this is the topic of it, but I'm trying to give a kind of general overview in like 20 or 30 minutes so we can get to some questions. Okay? And like I said, I'm really grateful for you all being here. This key of how far do you go? How far do you follow? You can, for some of us Christians, that's a question, but it's also for science. I mean, for doctors. If you're a gynecologist in this country, my friends at the University of Pittsburgh, McGee Women's, very strong contraceptive research and development, very strong abortion training. Well, you have to make these choices. The question is, if I'm a gynecologist and I need to walk the walk and talk the talk, would I be able to do this? If any of you all want an interesting read, it's from the Washington Post magazine, November 23rd, 2008. It's called A Hard Choice. A young medical student tries to decide if she has what it takes to join the diminishing ranks of abortion providers. Pat Meisel wrote it. And it's fascinating because it was almost like my experience. So the question is, Carol Myers, the gynecologist who was teaching the students this, so you think you're pro-choice, or in some cases, if you think you're pro-life, how pro-choice or how pro-life are you? What does it mean for you? What's your limit? Will you do an abortion on a woman who is 12 weeks pregnant, not 6? Will you do it at 24 weeks pregnant? What's your limit with birth defects? Would you do an abortion at 28 weeks if the baby had a club foot? What about hemophilia? This is part of the article. If you're going to perform abortions, how's your family going to feel? Well, I have to tell you, when my dad asked me what I was doing, I kind of lied to him for the first time. I said, no, I don't do those. And yet, in my residency, I wanted to do all of them because I wanted to be a good doctor. I wanted to walk the walk. I wanted to do the electives. I wanted to do. So hopefully today is going to be a lot of experiential as well as scientific, because I want conversation. I want thought. Because I think my talk today is filled with stories. So here I am in my residency, and this was back in the old days when we were still doing quad screens to check for genetic problems in the baby. And I get a quad screen that came back on a woman that was about, 14 weeks at the time, 15 weeks. So the fetus was, maybe 300 grams, 200 grams big. And the test was positive, but the risk went from 1 in 10,000 to 1 in 8,000. The boyfriend said, hey, that's great. 1 in 8,000, that's not a lot. His girlfriend said, no, that's too much for me. Get it out of me. So I took out, through a D&E, a 14-week fetus. A D&E is the procedure where you actually dismember. And so what happened to me over the course of my 2 years of residency is that I began to notice that I was becoming hard-hearted. Meaning, and I have to tell you, it's the same thing that this young medical student, really interesting woman, first name Leslie, at University of Maryland, grew up in a very kind of progressive household, really believed in a woman's right to choose, wanted to go to OBGYN, wanted to provide the services that many doctors couldn't find that they could do. And it's fascinating. She talks about the practicing on papayas at the papaya workshop. She found some of the instruments were very hard and very revolting almost. But it was just a papaya, and she eventually got the hang of it. And then she went into the clinic in her 3rd year, and she chose to go perform abortions with a supervisor and witness abortions. And with her first one, she said, the papayas don't scream or cry. Maybe after seeing 1,000 of them, she said, I'll get used to it. Well, I can tell you that trying to get used to it for me was really challenging. We talk about the 8 inches of a curette or the 10 inches of a pair of forceps, pliers basically, Haney clamps. What happens is that there's a dynamic that occurs not only between fetus and the mother, but also between the fetus and the doctor. And I found myself getting more and more and more callous. I'm getting dizzy. No. I'm not one of those medical students for life. I'm a medical student for choice. I am getting dizzy, but I'm not one of those. The second procedure was easier, she says. The doctor put Leslie's hand on the instrument, his hand over hers, and she let herself be guided by him using the dilator suction machine and finally the metal loop for scraping the uterus. And this is what was very common to her experience as well as mine. It was definitely gruesome. You could make out what a fetus looked like, tiny feet, lungs, but it didn't look like a person. She knew this abortion was an act that her friend Liddy considered tantamount to murder. That was the young lady on the Students for Life. The conversations they had over lunches like this. She herself expected to be very upset. She felt that way after her first autopsy, that of a teenage boy who shot himself in the head. She didn't regard the fetus as a person yet. That's at the heart of this. Not so much a person, but is it human life? That's really the question that really struggles for many of us. And yet, more and more we hear now that, well, it doesn't matter if it's a life. We have to have this process because it is legal in today. She said she was happy to help the woman. I felt like I was giving her a new lease on life. Later that morning, though, while conducting a pelvic exam, Leslie noted that she wasn't her usual slow, gentle self. That evening, discussing the second-term abortion with her mother, Leslie described a process that she found disturbingly brutal, especially the stretching of the cervix and the vagina. It's a lot more invasive than I thought, she said. And then her comment was, a papaya doesn't scream and bleed. Women do. And then it was a real disappointment to her that she couldn't do it. And to me, at a point, it was a disappointment. I couldn't do this. In fact, through medical data and through a change of heart, I stopped doing abortions because it was like a conglomeration of people talking to me, the data I was reading in our medical journals, as well as what I was talking to others about, how hard and difficult this procedure is. Vacuuming out a uterus and counting the parts of the fetus did not seem like a desirable way to spend her work days. She didn't want to let people down. She still was passionate about abortion rights, and she was proud at what she did with her activism. Well, I have to tell you, I was kind of there. So I had this kind of change of heart in the middle of that, between my second and third year of medical school, of residency. Some of it, I'm sure, was spiritual. I'm sure my parents, for any, Christians in the audience, they were praying for me, I guess. That was the data that I was talking to. And my own experience, I found myself kind of inverted on this topic. And now, being pro-life, how far do you go? How far, just like trying to do the abortion, first, second, third trimester, how far do you go? And the challenge is it's almost psychotic. Because on labor and delivery, based on the wantedness of the pregnancy, you're trying to save a life in one room and getting rid of a life in the next room. And it's very hard to go from one to the next to the next. Psychologically, it's what we all talk about. Schizophrenic. Because in one room at 23, 24, 25 weeks, so back when I was a resident, 25 weeks was kind of the cutoff. Well, we're now down to about 23 and a half weeks, and sometimes we admit them at 22 weeks over at Inova Fairfax. And so the question is that here I was in my residency, and I still remember this, and I kind of tell this story. Oh my gosh. This is for me. So I had this lady, her water broke at about 22 weeks. She didn't want the baby. In the next room, I had a lady, water broke at 23 weeks. She wanted the baby. And we're going to get back to wanted versus welcomed in a few minutes here. And so I remember pitting out. You guys haven't even done your OB electives, have you yet? So you use Pitocin, oxytocin, to help stimulate contractions. And it's called pitting out. You kind of have a problem, and you just have to empty the uterus. And we now sometimes use Cytotec and some other medications, but back then it was pitting out. And I remember this fetus, because it's only, at 22, 23 weeks, it's about this big. And I wasn't going to dismember this one. I was just going to deliver it. And so it came out. The mother didn't want it. But I knew I was close, so I had to weigh it. Because so I trained at the Eastern Virginia School of Medicine, the home of the Jones Institute for Reproductive Medicine, the first IVF program in this country. Howard and Georgiana Jones from the Johns Hopkins University came down right before I got there and began to do their program there. So it was a great education. We were a contraceptive research and development station for the nation, one of a few. But I remember the fetus came out, the baby came out. I grabbed it by its head, and I just kind of put it down on the scale. And it said like 510 grams. Guess what? In most hospitals, if a fetus or baby is under 500 grams, you can do with it what you want. You can toss it in a bucket. You can send it to pathology. It doesn't really exist. 510 grams. Little sign here reminds us, anything over 500 grams, you got to call the NICU, the Neonatal Intensive Care Unit. Now, this is, I hit the button, all of a sudden, in rushes in the ICU for preterm children. And I remember Dr. Plum walking by going, "What are you doing? You giving me a tumor again? You're better than this." I have a mother on the table that didn't want the child in the first place, I was being a doctor trying to save the lady in the room next to her. I'm trying to deliver this woman right now, right in front of me. Schizophrenic. The mother doesn't want it. The NICU doctor says, I've got to now full court press this child, intubate, to resuscitate, zipped away to the nursery. That was part of my conversion. That was part of my medical conversion. Based on weight, you decide to save something. Based on wantedness, you decide to save something. Oh, it's a tough decision. I'm not throwing stones here at all, especially for any one of us who've been through the abortion procedure. Or, I'm telling you folks, this child changed my whole world. And it was that schizophrenia that I really wanted to kind of get across to you all. And the arbitrariness of life. Okay? So there are some principles now, because we're going to go ahead with some of the hard cases as we just kind of go forward and open up for questions, is that we have some principles where we talk about you never pit the mother against the child. So, for instance, you never say you're going to end the pregnancy in order to save the mother's life. We talk about getting both mom and baby as far as we can, because mothers often, they're afraid, don't get me wrong, when they're hemorrhaging and the husband's looking at you or the partner's looking at you and you're trying to save both, it's a big deal. You never pit the mother against the child. It's never an unjust aggressor in the philosophical world. It's not a fetus. You don't kind of downplay it. Remember, most of these hard cases, these women are really engaged. Whether it's been, even with incest and rape, they're still going through those horrible emotions. When you have a sick infant or an infant incompatible with life, it's the same thing. You go from an ultrasound where the baby has no skull or brain with anencephaly, and then you need to end this delivery in like 48 hours. We need to induce you. What? Yeah, okay, I trust you. Here's your child outside of you, not breathing, passed away. That dynamic, never pit one against the other. Even with rape and incest, there's this violation. And when you look at the literature, you hear these women talk about how having the baby empowered them. Actually, the baby is now accompanying them forward in life. Something good came out of something horrible. We'll talk about some data on that in a minute. The other question about in vitro fertilization, this is another question I want to throw out to you all. I usually tell moms and dads, because we're a regular OBGYN practice, we send many of our really hard cases to places like Georgetown, Fairfax Hospital. I used to work in places like that, but now I'm an OBGYN. But we still do a lot of high risk in our own practice. So say you have a woman with infertility, and she's really looking at going to IVF, right? You all know what IVF is? Okay. So my question to them, simply put, is the embryos that they're going to make, the zygotes, the embryos that you're going to make, because that's what we do. That's what they do. Are they your child? Or are they your property? Do you love them or do you own them? It's a big question to ask because it's not an easy answer. Don't get me wrong, this is not a philosophy class. But when you engage a woman and a man at that level, they have to discuss certain questions that never come up on dates going to, Ruby Tuesdays or Five Guys. Do you love it or do you own it? Because if I freeze it, if I make 16 embryos to put back 2, and there's an inefficiency there, all of a sudden, the mother who believes those are her children, what am I doing? I'm freezing them. If I only use 1, but I have 4 frozen, what do I do with those? You hear about embryo adoption or snowflake adoptions. And the reality is there's hundreds of thousands, probably millions of frozen embryos across the country. Probably tens of millions across the world. So it's these type of questions that you ask because we believe at the Tepeyac Center that health is based on relationships. One of the neat things is that some of you guys and gals, you're becoming friends here, I'm sure. Like when I walked in, you three, I don't know if you know each other that well, but I would guess you do. You all made eye contact. She quickly stood up and got me this water up here. I really mean it. That's what medical school does to you. It bonds you. And it bonds you sometimes to do things, good and bad, tough and everything's hard. And so this idea that you're going to kick ideas off one another, this idea of the humanity, the dignity of the embryo, as much as the challenge of the woman. It's both and. It's not either or. How should we treat an innocent human being that reminds us of a painful event? The woman who's been raped and there's a child fetus growing inside. The hormones, the engagement, the surprise, the shock, the trauma. Do you know the feelings that women have after being raped? And once again, my heart goes out to anyone here who's been date raped or had injustices done to them. It's very similar to the pain and suffering that women with post-traumatic stress from having the abortion undergo. We're going to talk about that here in a minute, okay? Now, I'm going to kind of go through this. It's 12:30. Hopefully, we'll finish up by, 1:45. So these are the cases that I was talking about. Remember, the incidence of the hard cases, what do you think it is? Out of what percent of all the abortions done do you think are done for hard cases? Some people say 0.6%. Some people say 3%. I had one study that showed that if you include depression and anxiety, 1 in 43 or 2.5%. Rape and incest, 1 out of 770. Abortions done for fetal birth defects or a eugenic kind of approach, 1 out of 170. That's just one of many studies, and it's kind of representative. So once again, they're not common. And remember, once again, these numbers are, I used these numbers when I was in my other side I believed in abortion on demand. I believed in abortion for any reason, at any time, at any stretch of the pregnancy. I believed that because I believed it was a woman's right. It was good health care. Well, I had my change of heart, and now we have this dynamic that we always would say, oh yeah, it's the hard cases. What about rape? What about incest? And it's basically pointing out that you're really insensitive. My issue is I wanted it on demand for all the time, but I'm going to use these 2 or 3% of cases to show that you're just not a good human being. And it was tough. It was really tough. So one is this life of the mother issue. And I'm going to tell you the story of Blue Betty. I'm at a Catholic hospital in Norfolk, Virginia. And Blue Betty comes walking down the hallway. I saw her earlier in the pregnancy. She refused to go to her doctor, her cardiologist. She had a little bit of pulmonary hypertension. Guess what? It got worse. She was 24 and a half weeks along. She's walking down the hallway, and she might have been as blue as this gentleman's jacket. She barely could walk. I quickly do a check. The baby fetus is still alive. I call up my attending or my senior resident, get her to Norfolk General. We will quickly abort her and get her better. Once again, we do that. I follow them because I'm interested. Blue Betty passed away with fluid overload because we didn't take her to the ICU like we should have. We rushed her to get the abortion done. And we didn't know what her wedge pressure was. We didn't know what her pulmonary vasculature, we thought we did. And we thought, well, we're just going to break it up. And so Blue Betty passed away, both fetus and mom. This idea of the life of the mother. Once again, most of the time we try our best. And once again, the people here at this university do this excellently. You try to get them as far along as possible. You don't pit mom against, you have two patients as an OBGYN. Mom and fetus, mom and baby, especially when mom's sick. And so once again, this idea that you try to move them as far along as possible to a place where the fetus, the baby, has a chance to live outside of mom. One of the more common things about the life of the mother that happens to us as OBs all the time is what happens when water breaks at 6 weeks, 8 weeks, 12 weeks. And the uterine lining is connected to the vagina, and the vagina then passes some microbes up, and you develop chorioamnionitis, an infection. Well, we have to then deliver the mom. We deliver the fetus. We deliver the baby. Why? Because we're preventing infection. That infection can lead to sepsis. So that's the most common cause of a mother's life who could be in jeopardy because of sepsis and infection. And sadly, we have to do that. But we're not directly. What I try to tell patients is that some of these cases are incredibly difficult. And everybody has their stories, whoever's been an OBGYN. I'm telling you, you never pit mom against her baby, her fetus, and you try to move both of them as far along as possible. And in my case now, as a more of a kind of a non-abortion, pro-life doctor, I will never try to directly end the life of the child. Meaning, if I'm doing it, I'm trying to help with the medical condition that's there. So that's essentially, and once again, even Alan Guttmacher, who I used to read long ago, he talked about how most times, there's a quote, today it's possible for almost any patient to be brought through a pregnancy alive unless she suffers from a fatal disease such as a cancer and leukemia. And abortion would be unlikely to prolong or less save her life. This idea of chorioamnionitis is very common. I wanted to share it with you. Let me talk a little bit about rape here for the next few minutes. Let me tell you the story of San Diego, Virginia. So I'm a first-year resident in Norfolk, and I'm on call, and I get this woman coming in who's kind of has a big belly, doesn't have a lot of medical history, and I sit down with her because I'm the one or two, the intern or the second year on call, and hey, Glenda, how are you? Yeah. So where do you live? Oh, I live in San Diego. I go, wow, you live in San Diego. I go, where, is that near Suffolk, Virginia? Or is that near Richmond? Or is that near? She goes, no, San Diego, California. I said, wow, that's great. How long you been here? Because she's this kind of middle-aged African-American lady, very good eye contact, but she showed up in labor. I said, so San Diego, Virginia, San Diego, California, what brings you here? She goes, well, I go, so how long you been here, living here? She goes, oh, I don't know, 3-4 hours. 3-4 hours, and you came all the way over and you drove. I said, let me ask you some basic questions, being a good doctor. How many pregnancies have you had, Glenda? Because remember, I'm the first one to engage her. Oh, 11. Okay. Do you have any delivered? No, but I am going to deliver this one. Tell me, what's going on? Well, sir, I'm not proud of it, but I had a few elective abortions early. Then I've been raped by friends and family members, and I was kind of put through this cycle of abortion, keep your mouth shut, abortion, keep your mouth shut, abortion, keep your mouth shut. I finally got in my car with my dog, and I just drove out. I said, what's the furthest point west? She got on 66, got on 65, and ended up in Norfolk, Virginia. This idea of how do you treat an innocent human being that reminds us of a painful event? This whole idea, it's a very, very, very important question. There are studies out there that show that most women, 60 to 70% of women, will actually, after a rape and a conception, go on to keep their child. They actually see that the birth of the child is actually a good thing. And that gave me pause the first time I saw that data. That gave me pause. if I'm trying to believe that abortion is always the best response to a rape because it's going to make you very uncomfortable and actually very sick, how do I explain that? How do I explain that? There are also studies out there to show that for those women who went on to have abortions after a rape or incest, 70 to 75% say they actually regret that choice. That it's almost prolonging the insult, prolonging the injustice. And that rather than kind of stopping it here and now, I'm just promoting it. Once again, this is not for everybody. Don't get me wrong here. But I am telling you that when people simply say that abortion is the best answer for rape and incest, there's a lot of data out there that is interesting, at least, on that simple, basic assumption. Okay? Let's see here. This whole idea of, how do you feel about your toddler whose parents, are drug addicts and maybe was the product of a rape? Do you think any less of the toddler who has the same kind of genes and parental history of the fetus? These are things that I just came to grapple with, and I kind of said, there can be another way to do this. It's about 20 till. I'm going to move on a little bit here. The next area was kind of cases that are incompatible with life, and or not incompatible with life, but children who are sick. One of the cases that come up is Down syndrome. How far do you go? Will you abort a Down syndrome child? Well, I did. It was a woman's right. I did it. I still remember my cousin Mike, who also had Down syndrome, at a Christmas party one year, asked me if he was an endangered species. Profoundly affected me. 9 out of 10 Down syndrome fetuses or unborn children with Down syndrome are aborted today in this country. And yet this idea that he was an endangered species, this idea that preborn children who may be disabled it's nothing more than eugenics. We need better from the healthy. It's an interesting process of, we talked about health is based on relationships at our place. You want a relationship between you and the patient, she and her family, or area of support. One of the other principles is that medicine becomes an act of mercy. We're a nonprofit center. We see the underserved. We see them daily in our practice. We see the served. We see people with insurance. We see families with insurance. We talk about it's an act of mercy, not a political football. I'm sure you guys are you're being engaged by the changes in healthcare right now. You got to serve. You got to give back to your community. The third piece I want to talk about is you hate the disease, but you care and love for the patient. You don't get rid of diseases by getting rid of patients with the disease. And once again, when people talk about is it merciful, is it healthy, this is all part of feelings and this kind of inability to communicate one-on-one, to actually help people, because there are people out there who will step out of their way to help those with genetic anomalies. Or the next case I want to talk about is the cases that are incompatible with life. Byron Calhoun, an MFM out of West Virginia, he coined the term and the concept of perinatal hospice. So one of the things we do at our office is a perinatal hospice. Let me kind of give you this. So we use the womb as a hospice. We get the sick baby and the mother who's devastated and the family devastated to try to spend as much time as they can and then deliver the child and then celebrate the child's life rather than end it early. I have found that I've done it both ways, and I can't tell you the incredible benefit of this perinatal hospice concept. And these are for children who have illnesses that are quote-unquote fatally flawed, incompatible with life. You actually engage the mom and dad and family to spend time with these sick children, because that's the only time they have. Let me give you this brief story, and then I'll close it here. One is, it's called The Monster. I had metastatic testicular cancer, embryonal cell. I had a positive pregnancy test as one of the tumor markers. And I'm getting chemotherapy done. The group that covered me while I was sick getting chemo were the abortionists at our hospital. Why? Because we don't throw stones at people. We help them out. When they needed trouble or I got into trouble, hey, we just rush in and help each other. So here they are helping me during one of my illnesses. I remember him knocking. It's about 11 o'clock. I'm in my third round of chemo. I'm sweating profusely, more than I'm doing now. I'm 100 pounds over what I am now. He goes, what in God's name? What the hell are you doing? I just effing delivered your monster. I said, oh, God, Bob, I'm so sorry. I didn't tell you. Yeah, they did have anencephaly. But they chose to kind of spend time. They don't want, no. Yeah, John, everything was taken care of. Nobody got called. The NICU didn't get called. Everybody was good. But that was a monster. You should have told me. I'm not helping you anymore. So now let's fast forward at about, I don't know, a year maybe 2. Get a note, I get a knock, so now I'm back at work, knock at the door, Bob walks in, the guy that was there yelling at me. He goes, hey man, he goes, I just got back from Yugoslavia working with the UN trying to identify bodies. This was back in the Bosnian conflict. He goes, I just want you to know that I took a picture of Dubrovnik for you. I love Dubrovnik. It's a great city, it's got a great medical history to it about the plague and how it prevented it and all this other stuff. That's another story. He goes, I just took this picture because I wanted to thank you. I said, like, for what? Like, I don't remember really, like, we didn't really pass too much. He says to me, point blank, he goes, can I sit? You have 2 minutes. He sits down. He goes, John, he goes, do you remember the monster I delivered? I said, yeah. He says, I want you to know that I have spent my whole career trying to build that relationship, that health, that compassion, that love in my practice. I never saw more love, caring, and compassion in that family that delivered that baby without a skull and without a brain ever in the history of my career. And I've been a doctor now almost 30 years. He says, I can't do terminations anymore for fatally flawed kids. I would like to know how to do perinatal hospice. Once again, this is not, I'm just trying to give you some insights. It's about 1:15. I'm going to end it here. It's just for some questions. But this concept of perinatal hospice, where you accompany the woman and the child and the family as far as you can go, and then you can do those things that Kubler-Ross talks about. I love you, I'm sorry, please forgive me, I forgive you, and goodbye. One of the things that I find out when I was doing terminations and just delivering early, mothers never talked about their children. They never talked about like how sick the child was. Many times the other children didn't even know that they had a brother or sister who had the anomaly. In every one of these other cases, there's a lot of pain and suffering, but there's incredible conversation. And so from that standpoint, it has really made a big difference in our practice. And now there's more people and docs and hospitals trying to offer that as an option. Kind of, this is another option for you. Okay? I'm grateful that you were able, for the last 30 minutes, I'm so grateful for this. I'm going to end it here.